Hello, I'm Dr. Carol Vandenakker. I'm going to be talking about the components of comprehensive post-polio management. Management of post-polio syndrome has a number of different aspects. We often manage and treat the primary symptoms, but in addition, treatment includes identifying underlying pathology, which may or may not be related to polio, treating associated conditions that are linked to polio but not a direct effect, and optimizing health and promoting wellness. The second two are applicable also to patients who are survivors of polio but do not have post-polio syndrome, which is often about a third of the population seen in a post-polio clinic. The treatment plan has to be individualized to a patient. Polio survivors are all unique, all different, and there is no pattern that applies to everyone. So the way I start is a very detailed medical assessment. This is examination of the polio history, medical history, current medical problems, medications, and of course the physical exam. The physical exam, again, because every polio patient is very different, is very important to do careful muscle testing of the individual muscle groups and the joints. It's important to recognize and address any associated medical, neurologic, musculoskeletal, or psychological conditions. And there are often associated conditions that exacerbate post-polio syndrome. It's also important to identify areas of the body that are weak or at risk, and that may be muscles at risk, joints at risk, or risk of falls and other injuries. Lastly, it's important to speak with the patient about their priorities. There may be associated conditions that they're not concerned about. You always want to focus on what the patient's priorities are. The goals of treating post-polio syndrome is not to cure it, there is no cure. It is to minimize the symptoms. We do that by optimizing body mechanics, by protecting weak muscles and joints through various means that I'll address later, by treating any associated conditions, and a lot of those are more treatable than the post-polio syndrome itself, optimizing wellness, and looking at psychosocial aspects of life and decreasing physical demands and psychological stress. The tools we use for treatment include exercise, that can include stretching, strengthening, aerobic conditioning. We use a lot of activity modification or pacing of activities. We may be using bracing options and mobility aids. In physical therapy, we might be using physical modalities to reduce pain and inflammation. Often we address dietary changes, medications and supplements. And then there's complementary medicine, things like acupuncture and yoga and cognitive behavioral therapy that can be very useful. Psychosocial intervention may be indicated, and at times even surgery, although there are risks to surgery unique to polio survivors, and we take surgery very seriously before we recommend it. The symptoms of post-polio syndrome are excessive fatigue, that's the one most commonly seen, muscle and or joint pain, new weakness and or atrophy in polio-affected muscles, or muscles that were thought to be unaffected, although those usually have just been affected to a lesser degree. We also see cold intolerance, and in a subgroup of patient, problems with swallowing and respiration. Managing fatigue can be difficult. There is no direct link to any specific pathology that has been identified. And so at this point, although some medications have been trialed, we do not have a good medication therapy for fatigue. That means we use symptom management to a large degree. That means energy conservation, not using all your energy in one activity, but pacing activities through the day or through the week. making sure that the patient's biomechanics are as efficient as possible so excess energy isn't used. Maintaining ideal body weight makes a big difference in fatigue, as well as maintaining as much of a degree as cardiovascular conditioning as is possible. Interspersing rest with activities is very helpful, and also making sure that sleep is adequate and that patients are sleeping well through the night is important. There will be a talk later about sleep, so I won't go into a lot of detail on that, but that is a big component to fatigue. Often it includes addressing work, job requirements, lifestyle, hobbies, how a patient is using their energy need to be looked at and perhaps modified. Medications that have been trialed include modafinil, which in some patients seem to have a result, but in most does not make a big difference. And more current research is looking at the use of IV immunoglobulins, which may still prove to be useful but has not been completely established. Pain is another big factor of post-polio syndrome, and there are different types of pain that we see in patients with polio. Probably the most common one is the post-polio muscle pain, secondary to overuse and damage to the muscle tissue itself. To manage the post-polio muscle pain, the polio survivor themselves must learn to avoid overusing those weak muscles, to be able to recognize their own body symptoms and signals that they have overdone and adjust activity levels accordingly. Stretching to reduce increased muscle tension and physical modalities, especially in areas of inflammation or strain, are also very helpful for that pain. Often just using heat, a hot bath, or heat before going to bed can be very helpful. There is also a lot of soft tissue injuries we see associated with polio because of the body mechanics and increased stress on ligaments, joints, and tendons. Again, the rule of thumb is to rest the area that has been overstressed. That may include correcting body mechanics. It may be changing activities or using a mobility aid for a period of time to let that inflammation subside. If it's a chronic condition, that may mean going to bracing or use of a cane or walker or scooter. Modalities and anti-inflammatories can be helpful for acute inflammatory conditions, but in general, we don't recommend long-term use of anti-inflammatories as it can increase risk of ulcers. Pain from degenerative disease is also common. This can occur in the spine, in joints, where there is osteoarthritis or degeneration in the spine that may cause pinched nerves. Again, we're looking at body mechanics, looking at why those areas are being stressed. Is it something we can change with use of exercise, stretching, bracing, use of assistive devices? Sometimes it's a matter of weight loss. Physical therapy is very helpful in these conditions. Medication, less so, but certainly in an acute condition of pain is helpful. Bone pain is less common, but certainly we see that as well, especially when patients have developed secondary osteoporosis and possible fractures, either from trauma or spontaneous fractures if osteoporosis is severe. Pain management, as I stated, includes standard therapies and modalities. Heat and ice are always available, and heat can be a polio survivor's best friend. The pain medications, I spoke about the anti-inflammatories for the acute inflammatory conditions, but for more chronic pain or more neurogenic pain, we use antidepressants and neurotropic medications. A lot of these are the newer categories of antidepressants, the SSRIs, the SNRIs, as well as the anti-seizure medications. Narcotics are a last resort. Long-term narcotic use is not ideal. It affects body chemistries, reduces pain tolerance, and often requires increased dosing that then will cause complications with constipation and may depress respiration. Alternative therapies can include things like acupuncture and yoga, biofeedback, massage to areas where there is muscle imbalance. And lastly, psychological understanding and acceptance of pain can certainly help pain tolerance. Cognitive behavioral therapy is very useful in the management of pain, as is biofeedback. The weakness associated with post-polio syndrome may be due to overuse or underuse, or simply a matter of gradually losing more motor units and terminal sprouts. So one of the things to determine first is why a patient is getting weaker. Exercise is appropriate for most polio survivors. It has to be done carefully, but many studies have shown that a combination of strengthening, aerobic conditioning, and stretching can be beneficial. We know that deconditioning causes weakness in anybody, polio survivor or not, and that's a common exacerbating factor in the weakness of post-polio. It's important to look at which muscles you're going to target for strengthening. The advice that years ago came out of National Rehab Hospital determined that strengthening muscles that are a grade 3 or more is the most appropriate. It's also important to teach the polio survivor to recognize the signs of muscle overuse, the pain, cramping, twitching, those types of symptoms, and to reduce activity if they are seeing those symptoms after the activity or a day or two later. Weakness can also be managed with use of orthoses and assistive devices to improve the ability to continue to ambulate or maintain more efficient joint positions. And again, careful monitoring of symptoms is very important. Cold intolerance is a little less common, although that may be because many polio survivors like to move to warm climates. Cardiovascular conditioning does affect the degree of cold intolerance. So again, that is one of the things that can be promoted to reduce cold intolerance. Often it's simply a matter of learning to layer clothing and insulate better. It's important to make sure that the patient has utilities available, that there is adequate heating in their home, and many utility companies have special arrangements for patients who require availability of utilities in case of loss of electricity. They are on a priority list to maintain their access to power. You also want to assess for other conditions that may cause cold intolerance. Cardiac disease, peripheral vascular disease, neuropathies, and thyroid disorders are common causes of cold intolerance as people get older. And also there are certain medications, probably most notoriously the beta blockers, that can cause cold intolerance. Management of dysphagia or difficulty swallowing is not unusual to see in patients who had bulbar polio and weakness of the cranial nerves. Often the patient will report a history of choking or coughing when eating and drinking, or difficulty swallowing different types of foods. It may also be associated with a history of gastroesophageal reflux. So a patient certainly does need to be evaluated, both for possibility of reflux and their swallowing mechanism. We typically refer these patients to a speech pathologist who does the swallow studies and can teach compensatory techniques. If this becomes a very serious problem, they are referred to ENT physicians who may use more invasive management techniques. Respiratory problems, and again, this is something that will be addressed in another section, so I won't go into detail, but it's not unusual to see patients with restrictive lung disease. This may be associated with concurrent cardiovascular problems and may be more noticeable when a patient is lying supine. So you want to ask questions about their breathing at night as well as during the day. Treatments can include medications, assisted ventilation, and breathing exercises at times if it's not simply a matter of overuse and fatigue. The pathophysiology of post-polio syndrome includes loss of motor units and degeneration of axon sprouts. That was shown by Weikers and Hubble in '81, confirmed by Cashman's group in '87. There also is evidence that there may be neuromuscular transmission defects in some of the unstable motor units, and that there may be immunologic mechanisms at play. We also know that the process of aging is amplified in a polio survivor because of the lack of reserve in muscle tissue. Motor unit loss is difficult to treat. In some patients, it may be accelerated due to low testosterone level, and that if the testosterone level is measured as low, there may be benefit in testosterone replacement. More commonly, what we do is find the balance of muscle overuse to what a muscle can do to continue to maintain the strength it has. It's important to limit the demand on polio-affected muscles, so even when you may be advising exercise to strengthen and condition muscles, a more significantly affected polio muscle may have to be rested during those times. So you have to be creative in the form of exercise, possibly exercising just with upper extremities or a couple of the extremities and not involving all four. Again, bracing and mobility aids can help to protect weak muscles. The treatment of neuromuscular transmission defects was led to a large multi-center trial back in the late 1990s, looking at pyridostigmine or modafinil. And unfortunately, the result of the big study showed that there was no significant change in quality of life, including muscle strength, fatigue, and IGF-1 levels. But there was a later study that did show there was some slight improvement in walking performance. And it may be that in some patients, this is an appropriate medication to trial and may be effective for a select subpopulation. The potential treatment of immunologic factors is another hypothesis, that there are inflammatory cytokines that have remained in the central or in the cerebral spinal fluid following polio infection that may be contributing to the symptoms of fatigue, depression, and some of the more central nervous system symptoms. There have been pilot studies that show that there is some increase in quality of life, although the increase in muscle strength and performance could not be measured. There is another multi-center study that showed that there was some increase in muscle strength and increased vitality and physical activity, but it was, again, small improvements. This potential use of IV immunoglobulin continues to be studied to this day, so that may be updated in the near future. Common associated conditions that we see include arthritis and tendinitis, joint deformities, loss of range of motion, weight gain and deconditioning, sleep problems, and then chronic medical or psychological conditions. Treating these associated conditions, and again, these are conditions that may be present in any polio survivor, whether or not they have symptoms of post-polio syndrome, include, first of all, making sure the patient has appropriate primary medical care and is getting the appropriate treatment for any other medical illnesses. Associated conditions when it comes to the musculoskeletal system are often very amenable to treatment with physical therapy and changing body mechanics. The psychological aspect of it may be a little more difficult to address. Getting psychology involved, especially as people are first starting to lose function, can be very beneficial. Also, for the associated conditions, such as joint deformities or secondary nerve impingements, surgery actually may be your best option to change the body mechanics and get stress off a nerve or stabilize a joint. There are some medications that are potential problems for polio survivors. Probably the best known of this are the statins, or the cholesterol-lowering agents. They are known to have a side effect of muscle inflammation. And initially, as these medications came out, that was underreported. It also seemed that polio survivors were more sensitive to these medications than many of the general population. Some of the newer statin medications, like Pravachol and Lescol, have lower risk than the older agents. Increased fatigue can also be seen with use of beta blockers, benzodiazepines, or other anti-anxiety medications. Some of the neuromuscular blocking agents, muscle relaxants, narcotics, and alcohol. You also need to watch, especially if a patient is using narcotics and then in addition a laxative to counteract the constipation side effect. Use of diuretics or laxatives may deplete essential minerals and cause secondary problems with nerve and muscle function. Again, physical therapy for a lot of these associated conditions is very helpful. Use of strengthening targeted muscles, use of aerobic conditioning to improve endurance and cardiovascular function, and often use of stretching to improve the mechanics around a joint is essential. Because polio is not a symmetrical disease and an agonist muscle may be weakened while the antagonist is not, range of motion of a joint may be affected and contractures start to form. These then can significantly impact function, and this needs to be monitored and a good stretching program put into place if a patient tends toward this problem. Modalities also help with the joint and muscle pain. Modifying stress on joints with orthotics is also something to consider. There are a number of different types of braces and assistive devices, again, to be addressed in another session. But braces are very helpful to protect weak joints, to add stability to limbs, and to reduce the stress on weak muscles. Many patients find a significant improvement in their symptoms by use of a brace. But again, that needs to be countered with whether the patient can handle the weight of the brace added to the extremity and how much they actually are still ambulating. Bracing somebody who is ambulating minimally may not be useful. Surgical treatment is often musculoskeletal conditions that can't be treated with therapy. So we first try to impact musculoskeletal conditions with physical therapy or bracing, but if that is not enough, sometimes use of tendon transfers, tendon lengthening for contractures, actual osteotomies or straightening a bone, and fusing joints or the spine may be helpful. Oftentimes I recommend these in my younger population that still have many years, and if they are developing a joint deformity that could be stopped as far as progressing through surgery, that may be worth the risks associated with surgery. Total joint replacement does have an increased risk of complication in a polio-affected limb, and it's important to determine the strength of the muscle tissue and the quality of the bone density before recommending a joint replacement surgery in a polio survivor. But there are many polio-affected limbs or the good limb in a patient who has one limb affected that benefit from joint replacement surgery. It's of course important that the surgeon have some knowledge of polio. I like to talk with the surgeon myself prior to my patients going for surgical intervention. And also important that the anesthesiologist involved have some knowledge of polio as well and the risks associated with anesthesia. Promoting wellness is of course important to any patient you treat, but especially important to a polio survivor, because these tenets of just good medical care can make a person feel better, have more energy, and function better despite the other limitations. So again, having a good primary care provider is certainly essential. You need to look at what bad habits the patients may have and talk to them about those. Good nutrition is very important, as is restful sleep. Getting some degree of exercise is applicable to almost everybody except those most severely affected, where day-to-day life is exercise enough in and of itself. Preventing injuries, especially falls, is important. Looking at lifestyle and getting patients on a good balance of rest, regular meals, some degree of exercise, and then activities that keep them motivated and engaged in life is important. Having that emotional and mental health and support is also important. A lot of the polio support groups provide that in different communities, but even that can be provided by the family. Although at times the family doesn't understand post-polio syndrome and need a lot of education so that they are supportive of the polio survivor. The prognosis for post-polio syndrome is actually not terrible. It is not curable at this point, but it is slowly progressive. It has been shown in older studies that some of the muscle fatigue and subjective fatigue may stabilize over time. So typically what we see is a plateau sort of picture where someone may lose function but then stay at a plateau for many years before any further change. The most serious cases of post-polio syndrome are the ones that include respiratory dysfunction or swallowing problems, because those can lead to secondary lung infections, respiratory failure, and could cause death. But studies have shown us that rehab interventions can slow the progression of symptoms and improve function and quality of life in patients with post-polio syndrome. So certainly making the changes you can is worthwhile. Thank you.